Hi everyone. Today's topic is cataract, which is the most important topic in ophthalmology. First, let's see the definition of the cataract, that is, any opacification of lens or its capsule which impairs the optical homogeneity. Then the next one is the classification of the cataract. Classification of cataract. Broadly, the classification is based on one is etiology and the other one is the morphology. When we come to see includes the etiological classification, it has two types, that is congenital cataract and acquired cataract. In acquired cataract, we're gonna see many different subtypes in it. So here I have made a mnemonic to remember the types of acquired cataracts, that is see Dr. Stemmer. Here I have made C like this, so don't get confused. C, complicated cataract, dermatogenic cataract, senile, traumatic, toxic, electric, miscellaneous, metabolic, and radiational. So remember this, that is C, Dr. Stemmer. Okay, now let us see the morphological classification. Majorly it is like capsular, cortical, subcapsular, polar, and nuclear. Again, in capsular, it is anterior capsular, posterior capsular, which involves the anterior capsule and posterior capsule respectively. Then it is cortical, which involves the cortical area. Then subcapsular, which involves just beneath the capsule region. And then the polar, which involves the anterior pole and the posterior pole. Then the nuclear cataract, which involves the nucleus. I have mentioned this in different colors so that when you see the picture, you can understand whole the morphological classification very easily. As we have seen the classification, let us learn each one in detail. First is the congenital and developmental cataract. Congenital and developmental cataract. As I have told you in the previous video that the nucleus, depending upon the developmental age, it has different zones, that is the embryonic, fetal, infantile and adult nucleus. Here congenital and developmental mostly involves the first three, that is the embryonic, fetal or infantile nucleus. Let's see the etiology of the congenital type of cataracts, that is, I have made a simple mnemonic here, HIM. Here each factor, that is each etiological factor confers to 1/3 part of etiology to the cataract. H here refers to hereditary, which is genetic form. Mostly it would be the autosomal dominant, and the genes involved here are CRY, that is crystallins, connexins, MIP, that is the major intrinsic proteins. Then I here confers to idiopathic, that is of unknown cause. M is maternal and the fetal factors. Maternal factors would be the malnutrition, torch infections, that is toxoplasmosis, rubella, cytomegalovirus infections and herpes infections. Drugs usage during the pregnancy, that is thalidomide and corticosteroids. Any radiation exposure during the pregnancy may lead to the congenital cataract. And when we come to see the fetal or infantile factors, that is anoxia, decrease in the oxygen supplementation, birth trauma, malnutrition associated with any metabolic and congenital anomalies of the baby, that is metabolic or galactosemia. Congenital anomalies include Down syndrome, Lewis syndrome, Fabry syndrome. And the clinical types of congenital cataract, I have made it in a single paper so that once you look at this, you can learn everything about the clinical types of cataract. Majorly it's of 4 types, that is capsular, polar, nuclear and generalized cataract. Let us see one by one. That is capsular cataract, again is of anterior capsular, posterior capsular, which involves anterior and posterior capsule respectively. And then here the diminution of vision is not so marked. And when we come to see the polar cataracts, it is of anterior polar and posterior polar cataract, which involves anterior pole and posterior pole respectively. Anterior polar is due to delayed anterior chamber development or due to corneal perforation. It is bilateral in presentation. And the anterior polar is again having 3 types, that is thickened white plague type of cataract, anterior pyramidal, reduplicated cataract. Thickened white plague cataract is where the cataract looks like a white plague, and then the anterior pyramidal is the one, the cataract is in the pyramidal shape with the tip of the cone pointing towards the cornea. And then the reduplicated cataract is the one where immediately behind the portion of the anterior polar cataract, beneath the cataract, there is again seen the opacification of the fibers, and in between forms the normal fibers. So that's separating the two cataracts, that is the polar cataract and the beneath the cataract we are having the normal fibers. The beneath one, which is buried below, is called imprint, and the whole is called reduplicated cataract. And then we see the posterior polar cataract. Posterior polar cataract is again of two types, that is stationary cataract, progressive cataract. This is important, that is it gives the onion hole appearance. And then next is the nuclear type of cataract. Nuclear type of cataracts are again like broadly four types, that is cataracta, centralis purulenta, lamellar cataract, sutural and axial cataracts, total nuclear cataract. Cataracta centralis purulenta. See, just the name itself says everything. Cataracta, that is cataract. Centralis, exactly in the center, that is involving the embryonic nucleus of the lens. And then the purulenta, which represents the powdery form of the cataract. That is all about the cataracta centralis purulenta. And then is the lamellar cataract, which involves the fetal nucleus, that is just surrounding the embryonic nucleus, and then the regions just outer and inner to the cataract are clear, and just linear radial forms, linear radial opacities spread towards the cortical zone. Those are called riders, which is very important to remember in the lamellar cataract. And one thing is, it is the most common type causing the diminution of vision, Vitamin, that is etiology here is also very important, that is vitamin D deficiency leads to lamellar cataract. Then is sutural and axial cataracts. Here I have forgot to tell you the thing in the previous video is in the fetal nucleus, the lens fibers here forms at the connection, they forms the sutures, that is anteriorly they look Y-shaped sutures and posteriorly they look inverted Y-shape. So the cataract which forms along those sutures and along the axial line, or the sutural and axial cataracts, they are again of floriform, coralliform, anterior axial embryonic cataract. Floriform is the one where they form in the petals of the flower, coralliform where they look like corals. And then anterior axial embryonic cataract, where the cataract forms along the anterior axial line, anteriorly along the axial line. And the total nuclear cataract is the one where whole the nucleus is getting fully opaque, that is dense chalky white cataract, where the diminution of vision is very much. And then the generalized type of cataract, which is again having three types, that is coronary cataract, blue dot cataract, and the total congenital cataract. Coronary cataract, here the opacities are many hundreds in number, and they are arranged peripherally in a round shape around the axis in a radial manner. And here, as they are distributed peripherally, we don't see any diminution of vision. If these plaques are big enough so that they come into the center, then we see the diminution of the vision. And here the part of lens that is involved is the adult nucleus or the inner cortex part. And then the second type in the generalized cataracts is the blue dot cataract. This is the most common type of congenital cataract, the same as here. The opacities here or even distributed radially along the axis. Here is the same, as they are distributed peripherally. There is no diminution of the vision. If they are large enough, they come to the center and cause diminution of the vision. It is important to remember that blue dot type of cataract is the most common type of congenital cataract. Then total congenital cataract is the one where whole the lens gets involved, and it is again of hereditary, and maternal rubella is the one most important cause of congenital cataract. Now let us learn about the congenital rubella syndrome. That is, the infection during the first trimester of pregnancy, that is during the second and third month of pregnancy, is cause for the congenital rubella syndrome. Here it is a triad of three things, that is, it involves heart, eyes and the ear, causing deafness. So here the simple mnemonic for this is HOD, that is heart defects, ocular defects and deafness. Other than the congenital cataract which you are learning here, the rubella syndrome also involves the other ocular features, that is ocular defects, or I have made another mnemonic for this to remember. The ocular defects of congenital rubella syndrome, that is poor CM, 8, salt and pepper. Poor here confers to the poorly dilating pupil seen in the syndrome, and then the congenital cataract, M for microphthalmos, and then 8, the T ear small, and then A is angle anomaly, that is which is including glaucoma, and then salt and pepper fundus. Okay, and then in salt and pepper fundus, it is the most common feature in this syndrome. And then what is the cause of the salt and pepper fundus is due to diffuse chorioretinitis. Then let's see something about the congenital cataract in this case. That is the most commonly it is of nuclear pearly cataract. That is, the nucleus is pearly white in color, and then it's the second most common feature, where the salt and pepper being the first common feature. Then this is the congenital rubella syndrome, can be prevented by vaccine. But when it is given during the pregnancy, it is very toxic to the fetus, so it is given at least 3 months before the pregnancy, so that this can be prevented. And then in this, once the child acquires this congenital syndrome, then in the cataract the virus harbors for about 2 years. So any treatment for the cataract, any surgery over there, leads to the infection and much inflammation due to the virus presence over there. Then the management and treatment of congenital and the developmental cataract. It is, first we have to do the investigations, that is clinical and lab investigations, and we should know about the prognostic factors. Then what is the treatment? That is a surgical treatment. One important thing is, in case of cataract, there is no role of medicine in case of any prophylaxis or in case of any treatment. So it should be the surgical treatment. The only treatment is the surgical treatment. So let's see what are the investigations. There is a clinical and lab investigations that can be done in child. As the vision cannot be assessed, that is, any visual test cannot be accurately done to a child as it's not supportive. We check for density and morphology of the cataract through direct distant ophthalmoscope. That is, we should check for density and morphology of the cataract, where morphology of the cataract may tell you the cause of the cataract. And then lab investigations, we check for any infections, that is torch kind of infections. We check for galactosemia, any galactose in the blood, increase in glucose levels, hypocalcemia, and then Loeys syndrome. How we check for the Loeys syndrome is urine chromatography for amino acids. Then let's know the prognostic factors, that is the density of the cataract, whether it is the unilateral cataract or bilateral cataract. Mostly the unilateral cataracts are of more severe than the bilateral cataracts. And then the associated with, whether it's associated with any ocular defects or it is associated with any systemic defects, time of presentation of cataract. Then now let's see the treatment, that is the surgical treatment. Two things which are very important to know about in this surgical treatment of congenital cataract is when we have to operate and what we have to do. When we come to see when we have to operate, that is time of operation, first we should know about the foveal reflex. Foveal reflex is the one where it is also known as fixation reflex, where the fixation occurs. That is, when you see a very small child immediately born, he cannot look at a person constantly. That is, he cannot fix the image. It takes time for the fixation of the image to occur. That is the fixation reflex. It starts that, okay, let's see. And then for the fixation to occur, that is for the image to fall on the retina, the light rays have to come through cornea, lens, then to the fovea, then the image forms. So, By the time the foveal reflex forms, the lens should be normal. If in case of congenital cataract, the lens become opaque, no light rays fall on lens, though they may fall, they do not pass through the lens so that they do not form any image on the fovea, so that no foveal reflex, no matter of correction after the foveal reflex formation is over, because it's done. Whatever you may do, there is no use of. So the foveal reflex starts at 1.5 months and ends at 5 to 6 months of age. So we should do at the time period between these ages. So let's see the time of operation. In case of very small cataracts, there is no need of any surgical treatment, and then which do not disturb any vision. And then in case of bilateral cataracts, which is of comparatively less urgency when compared to the unilateral cataract, in unilateral cataract you should immediately, you should operate within 4 to 6 weeks, and in bilateral cataracts within the 3 months. Like there should be a few days gap between the operation of one eye and the other eye. And then, the ideal time we are saying is like 1 to 1.5 months, that is 4 to 6 weeks. Why not before the 1 month? Okay. Why not before the 1 month is, before the 1 month it may lead to aphakic glaucoma. And then the treatment of choice is between, like in textbook it's given less than 2 years and more than 2 years, but let's learn like this. If we operate in less than 1 year, or we operate if more than 1 year. If it's less than 1 year of age, we should do lensectomy. That is, we should remove the lens, sparing the anterior capsule rim at the first time when they visit. Then secondary IOL implantation. Secondary IOL implantation means it is at the second sitting. First, we should remove the lens. We should leave the anterior capsule rim. So we'll not be having the lens now. We should manage with the glasses or something like contact lenses till some age. Then in the second sitting, that is at the next time, we should implant an IOL, that is secondary IOL implantation. In spite of many efforts in these cases, you may get amblyopia. Amblyopia is where the partial loss of vision, that is, a vision is less than 6/6. In case of more than 1 year, the treatment is lensectomy plus primary posterior capsulotomy. That is, primary means in the first sitting itself, you remove the posterior capsule. Why? Because if you do the lensectomy, there may be more chances of getting the posterior capsule opacification due to intense inflammation over there. And we should do the anterior vitrectomy, where the inflammation may even spread to the vitreous, which is immediately present after the posterior capsule. And then the primary IOL implantation, that is in the first sitting itself, we remove the lens, we remove the posterior capsule, we remove a little part of the vitreous, anterior vitreous, and then in the same sitting we implant an IOL. That's it. The surgery will be done. And see, in both the cases you can see, in spite of all the efforts you have put, there may be the less correction, over correction or whatever, and may have amblyopia, that is a partial loss of vision, that is where the vision is less than 6/6. Then we have to give the treatment for amblyopia. There may be the need for usage of glasses or lens, whatever. Now let me show you some pictures of cataract which are present in the textbook. This is the posterior polar cataract, and here you can nicely see the zonian hole appearance, which is a typical feature of it. And then the next is the lamellar cataract, that is, you can nicely see the riders in this. This is a picture which we can see through the optical illumination through the slit lamp, and this is the clinical picture of the lamellar cataract, where you can nicely observe the riders. And then this is the anterior axial embryonic sutural cataract, where it is in Y shape, indicating its presence on sutures and it's on the axial line. And then this is the picture of the coronary cataract, where the here also this is through the slit lamp, and this is the clinical picture. And then this, see here, the opacities are peripherally present and in a radial manner, And then this is the picture of the total congenital cataract. As we have seen about the congenital cataract, let's see the few important points to remember here. That is, in posterior polar cataract, we see the onion hole appearance, and then the most common type of congenital cataract causing the diminution of vision the most is the lamellar cataract, and then the most common type of congenital cataract is the blue dot, which is causing most diminution of vision is lamellar, and the most common type is the blue dot cataract. Lamellar cataract. The another important thing is etiology is the vitamin D deficiency causes and riders or seen in it. Congenital rubella syndrome, where nuclear pearly cataract is seen and salt and pepper fundus is observed. Treatment, the ideal time is 4 to 6 weeks, and the overall treatment of choice is lensectomy plus primary posterior capsulotomy along with anterior vitrectomy and IOL. So this is wholly about congenital cataract. Thank you.